Well, welcome everybody to today's Telehealth Roundtable at the FCC. The FCC and its staff have been doing tremendous work to support not only sort of long-term telehealth trends that we've been doing for decades, but some new and emerging trends in telehealth. And I think it's great that we have an agency like the FCC that's sort of, if not ahead of the curve, at least with the curve when it comes to telehealth. And I want to start by introducing some of my FCC colleagues. They've all been very, very dedicated to telehealth. And I thought we would start with them offering a couple of words before we move into two panels. And we'll give it an opportunity for the panelists to tell us what they're doing, what they're learning, an opportunity to talk to each other as well about telehealth and their experiences and how we can build on the successes of the past year and address any shortcomings that we have. And so I want to start by turning over to my friend and colleague, the FCC chair, Jessica Rosenworcel. One of the very first events that she did as chair of this agency was a telehealth event, which shows her commitment to this cause. She invited me to join her for that at the Whitman Walker Clinic here in DC. We had a great experience there. And again, I think it just goes to show the early focus of this FCC and this chair on telehealth. So very pleased to have her kick us off with a couple of opening remarks.
Oh, thank you. And good morning and welcome virtually to today's Telehealth Roundtable. I really want to thank you all for joining us this morning, especially our panelists. If there is one positive of having events move online during the pandemic, it's that there's an opportunity for so many experts from across the country to participate. So thank you all for sharing your time and your expertise. Special thanks to Commissioner Carr for organizing this event and inviting me to participate. I really do appreciate Commissioner Carr's commitment to this issue. And frankly, I never thought there would be a part of his job that Commissioner Carr was more passionate about than proving that he can climb unbelievably tall cell towers. But it turns out that expanding access to telehealth can come close. And if you've seen how many tower climbing photos Brendan has on his social media feeds, you'll know that's saying something. But I also want to note that all four commissioners are participating in this morning's event. So thank you to Commissioner Starks and Commissioner Simington too. And make no mistake, we are unified in our commitment to maximizing the benefits of telehealth. In fact, as Brendan just said a minute ago, the very first person virtual field visits I actually did as acting chairwoman with my colleagues to see telehealth in action. Together with Commissioner Carr, we visited the Whitman Walker Clinic in Washington, D.C. And with Commissioner Starks, we held a virtual visit with telehealth experts at the University of Virginia. And with Commissioner Simington, we traveled to Children's National Hospital, where we learned how the hospital was using telehealth to serve families during the pandemic. And I'm really pleased to see that two of our hosts from those visits, including Dr. Karen Rubin from the University of Virginia and Dr. Ricardo Munoz from Children's, are among today's panelists. Now, when you serve on the FCC, one question that you are constantly being asked, whether it's on a panel discussion or during a media interview, is what's the next big thing? When are we going to see the next big breakthrough? And if you look across the technology landscape, you'd have a hard time coming up with something that has more potential to dramatically improve people's lives than digital health. Because after all, with ubiquitous broadband connectivity and wearable technologies, we are going to unlock dramatic advances in remote patient monitoring that will allow us to address health issues before they become health emergencies. Telehealth, of course, can also bring specialty care that was once only available in our most urban centers to smaller remote clinics and even further into the home. Digital health tools can not only improve patient outcomes and save lives, they can create new efficiencies in our healthcare systems and save time and resources. Now, for a long time, when we've talked about telemedicine, we've talked about its potential. It was something that would be widely deployed and deployed beyond our rural communities in the far future. But the pandemic changed all that. According to one analysis in the American Journal of Preventive Medicine, there's been a more than 20-fold increase in the use of telemedicine since the start of the pandemic, 20-fold. Now, I've seen different estimates, some are higher, some are lower, but the undeniable truth is that healthcare has changed during the pandemic and telehealth is here to stay. And thanks to two separate appropriations from Congress and of course the FCC's own Connected Care pilot program, we've been doing our part to expand the availability of telehealth during these challenging times. Last year's CARES Act provided $200 million for the FCC to establish a COVID-19 telehealth program, which funded over 500 applications and enabled the expanded use of telemedicine by community health centers, mental health clinics, nonprofit hospital systems, and a whole bunch of others all across the country. Now, this year, we've been working to implement phase 2 of that program with a $250 million budget. And as of late October, we awarded over $150 million. And we've been able to support healthcare providers in every state and territory, including right here in the District of Columbia. Now, these resources are being used to purchase connected devices hospitals can use to safely screen, diagnose, and treat patients. And they're also being used to support remote monitoring equipment so patients can continue to maintain care for themselves without risking a trip to the hospital or the clinic. We're also funding telehealth platforms and video equipment that allow healthcare professionals to conduct remote patient visits, among other uses. Now, some of today's panelists are grant recipients under these programs, so we're going to hear firsthand testimony about how these investments are making a difference. And while these programs were established to support telehealth services during the pandemic, my view is that when it comes to telehealth, there is no going back. There's no going back to the way things were. So we should be focused on consolidating the gains that we've made and building on that foundation. And by the way, that goes beyond broadband to making sure the whole of healthcare policy is organized to support the best that telemedicine has to offer. That means addressing insurance and reimbursement and state licensing practices that can make it challenging too. And whoa, that's a lot. But the possibilities are real and the proof is right there out in the open in that dynamic way. So many of these services have been deployed to positive effect during this pandemic. So I want to encourage all of today's panelists to think big and share their ideas on what the FCC can and should be doing to support the long-term expansion of telehealth services. So I've gone on for a while, but thank you again to everyone for participating. I look forward to working with all of you to fulfill the promise of telehealth. Thank you.
Well, thank you so much, Chair, for those kind remarks. I agree with you. This is going to be a great panel. And up next, my second favorite FCC commissioner from Kansas, Commissioner Jeffrey Starks. He is someone that has telehealth and healthcare in his blood, comes from a family of doctors, so he brings a passion to this issue and a perspective I think is very valuable at the FCC. He's a strong proponent for expanding telehealth. And again, that's been the key to how we've been able to get so much of this funding out the door the last year and a half. So I want to turn it over to my good friend, Commissioner Starks, to offer a couple words.
Well, thank you, Commissioner. Many of you are used to seeing me in my home office here with the brick background. But I'm at the kitchen table here today, like so many Americans that have to figure out how they're going to make their healthcare decisions, and they sit around the kitchen table and try to think about how they're going to make the hard decisions to bring their health better. And so thank you to Commissioner Carr for bringing us together here today and the group of experts that we're going to hear from to discuss many of the issues, including the FCC's telehealth programs, the broader telehealth landscape. For many years, the pressing need to expand access to healthcare has helped drive the Commission's efforts to get everyone online. And as Brendan mentioned, I come from a family of doctors. And so I have heard from each of them in their own way and their concerns, whether it's in Kansas and Missouri or Virginia and South Dakota. The concerns that they have, and it has motivated me to continue to work hard for a world where every American has high quality, affordable broadband at home. When we announced the COVID-19 telehealth program last April, it was clear that telehealth would play a mission critical role in addressing COVID-19. Even early in the pandemic, experts agreed that receiving care remotely could both meet patients' needs and also help prevent community spread of the coronavirus. And so as I look back and reflect back on the Commission's pandemic response, I'm especially proud that we launched the COVID-19 telehealth program so quickly in those early days, and then that it made so many high impact investments. And today, more than a year and a half into what is an ongoing public health crisis, we have ample evidence that telehealth has made an enormous difference in our nation's response. Researchers at the Urban Institute found that during the first 6 months of the pandemic, a third of Americans had a telehealth visit to discuss their own health care. There have been particularly striking increases in telehealth use by low-income Americans. Between March and June of 2020, the Center for Medicare and Medicaid Services found that telehealth visits for Medicaid and Children's Health Insurance Program, CHIP, beneficiaries increased by more than 2,600% compared to the same period in 2019. And so those beneficiaries received more than 34 million telehealth services in just 4 months, quarter of a year, a little over a quarter of a year. And so while many Americans are returning to in-person visits, McKinsey and company has found that telehealth utilization has stabilized at very high levels. And so, as many have already said, I completely agree, telehealth is here to stay. Through tens of millions of virtual visits, patients and healthcare providers have reduced those in-person contacts, maintained social distancing, of course, important measures, but patients have also clearly seen the benefits that have piqued interest in telehealth and increasing access to specialists, mitigating challenges like travel and health conditions. As so many of my colleagues have said, both encouraging rural folks to see the physician or the specialist that they need, but also folks who otherwise would have to hop on a bus and ride across town 30, 40 minutes in a city in order to see the physician that they need to see. Telehealth really drives impact there. And so those benefits are likely to make and continue telehealth usage. So with all these benefits in mind, I, of course, want to thank our panelists for coming. Thank you, Commissioner Carr, for convening us, and look forward to hearing from you all how we can continue to make sure that telehealth helps Americans everywhere. Thank you.
Thank you, Commissioner, for those great remarks. And next, another of my FCC colleagues, my favorite FCC commissioner from Canada ever, someone who actually has a background on the technology side, sort of focused on some of these exact same devices that can now be leveraged and used for telehealth services, and someone, Commissioner Simington, who has hit the ground running at the FCC, particularly when it comes to putting an oar in the water and making sure that we continue to make progress on these important telehealth services. So I want to turn the floor over to Commissioner Simington.
Well, thank you very much, Commissioner Carr, not just for your kind remarks, but for organizing today's roundtable and for bringing beyond that the telehealth issue to the forefront of the Commission's attention in the first place. So many of you will know, of course, that Commissioner Carr spearheaded the $100 million Connected Care pilot program early in his term as commissioner, and almost 2 years before the outbreak of COVID-19. So that's prescience, if you like. And doing so also laid the foundation for Congress to appropriate almost $500 million of telehealth funding during the pandemic. While I'm saying thank yous, I'd like to thank the medical industry professionals joining us in today's roundtable for their work in implementing telehealth programs covering a wide variety of technologies, capabilities, and increases in access. America is a very large country, of course, with a lot of people living very far away from medical services. For those people, the alternative to telehealth is a long time on the road and, as a practical matter, frequently not seeing a doctor at all. We know that early diagnosis and treatment is crucial for successful outcomes for many medical conditions. So being able to access medical care from home is quite literally an issue of life or death for millions of people in this country. During the pandemic, the need for telehealth services has been even greater than it was before. Many in-person medical facilities were only accepting patients with emergency or with scheduled critical procedures. And many people were scared that going to the doctor's office could mean exposing themselves to COVID-19. Preventative cancer screenings, for example, dropped over 94% over the first few months of the pandemic. The National Cancer Institute estimates that over the next decade, this alone will cause more than 10,000 otherwise preventable deaths. That estimate from June 2020 may understate the toll now that the COVID-19 state of exception in our society has lasted for almost 2 years and made it frightening for many people to engage in routine daily life, let alone go to medical facilities where they feel that there's a risk of coming into contact with COVID-19 patients. Getting people talking to a doctor and explaining their symptoms is how you get them back in the door at the outpatient center for a diagnostic procedure that can save their lives. But it's not always just about death or serious conditions. For mild or mysterious ailments, a short visit with a doctor can mean peace of mind and knowledge about how to get better, manage symptoms, avoid suffering the same condition in the future, and getting beyond lifestyle impediments that do not rise to life or death issues, but nonetheless decrease quality of life. I'm also excited about telehealth developments beyond just video visits with doctors, important though those are. It's increasingly possible to use home medical devices to capture patient health data over the internet. Connected blood sugar meters and insulin pumps can improve our understanding of each patient's unique condition and allow minute adjustments to be made on the fly instead of only on scheduled doctor's visits. Connected blood pressure monitors, pacemakers, and EKGs can diagnose and treat both acute and chronic heart conditions and help patients to win the race to get timely treatment. Sleep trackers can identify previously difficult to diagnose issues without costly inpatient sleep studies. And speaking from personal experience, those can also be very difficult to schedule. And the data produced by these devices can not only be analyzed manually, but also with analytics and artificial intelligence, saving time and money for both patients and doctors. The AI revolution in medicine has hit each field to a different extent. But for example, some of the promise that we've seen for computer-assisted readings of charts or of radiology scans has proved very encouraging, and no doubt it will only get better down the road. I hope that the FCC's large investment in telehealth helps make these technologies and more a reality for millions of Americans. If doctors and hospitals don't have great broadband connections and networking equipment, they can't hope to realize the promise of telehealth. So let me finish how I started, by commending Commissioner Carr for pioneering our work in this area, Chairwoman Rosenworcel for her continuing support, and Commissioner Starch for his deep involvement with it throughout, and also thanking the medical professionals for putting these funds to good uses that we couldn't possibly have done at a granular level at the Commission, using the benefit of their expertise and passionate concern for patient care. Thank you.
Well, thank you so much, Commissioner Simington, for your remarks and your commitment to this issue. And before we move on to the first panelist, for my part, I want to say that, I think this is, as Chairwoman Rosenworcel said, with COVID-19, we saw such a acceleration of use and adoption of telehealth technology. I was just in Parsons, Kansas a few weeks ago and met with officials there, and they said that their visits went from basically 0 telehealth visits before the pandemic to over 1,200 visits a month. And so this just massive spike in telehealth is something that we've seen nationwide. And over about the past 2 years or so, I've had the chance to meet with about 44 different healthcare providers across 22 different states, from Alaska, the Mississippi Delta, down to Florida. And I've consistently heard this story about these spikes in telehealth usage. I've met with a lot of the panelists that are speaking today at their own healthcare facilities. I've heard about the different issues that they have been working through. And I thought that a forum like this that gets different healthcare providers, including a number that have gotten awards through various FCC programs together, is the beginning of a conversation. So we at the FCC can learn what's working, what's not in our funding programs, and for you all to meet each other to the extent you don't know each other, talk with each other, share lessons learned to make sure that the benefits that we're seeing from telehealth continue. The first panel that we're going to talk about is a bit more on some of the practical and the implementation challenges. The second panel will talk a little bit more about some of the legal frameworks, HHS waivers, different issues like that, but I'm sure there's going to be a blending of different conversations across the panel. So I'm really looking forward to it. Again, I think this stuff has been life-changing. I was just in, I guess I'm not quite sure when the first time was I met Dr. Ruban, who's on our first panel, but it's sort of been off to the races ever since I met her, at least back in 2018, and really opened my eyes to a lot of the technology changes that are going on in telehealth and where the FCC can help support it. And when we announced the rulemaking for the proceeding that resulted in connected care, I was at an event with Dr. Ruban down at Laurel Forks, Virginia. And that's where I met a woman actually at the event afterwards. She came up to me. Her name was Kathleen. She had diabetes and she had stopped going to her doctor. It was, multiple hours travel, difficult scheduling. And she decided just to ignore the issue like so many people end up doing. Her A1C levels, if I remember, had skyrocketed to something like 15.5, which is usually associated with a lot of chronic conditions or worse. But she got into a remote patient monitoring program, and it was a life changer. She had like so many patients, a blood glucose monitor that she took home, kept connected. Her numbers came down. She said she never felt better. And importantly, that day that we met, she told me she was going to court actually to get custody of her grandkids, and that she said that she simply would not have been in the physical shape or the ability to take over care for her grandkids had it not been for levels coming down, and thanks to telehealth. So there's so many benefits from this program, and I'm personally very grateful to Dr. Ruban, to so many others for leading the way and getting the FCC positioned so that when COVID-19 hit, we had done a lot of the regulatory legwork that we needed to do to stand up these programs at the most important time. I look forward to building on that. And so with that, let me introduce the first panel, Dr. Karen Ruban. She's the co-founder and director of the University of Virginia Telehealth and wrote the book on telehealth. Dr. Ricardo Munoz, who's the executive director of telemedicine at Children's National Hospital. Dr. Robert Donnell, he's the chief medical officer at the University of Florida. Stuart Clary, who's the director of telehealth services for University of Florida Health. And Dr. Shireen Atabaki, the director of pediatric emergency medicine at Children's National Hospital. And so to kick it off, why don't we just go through with a couple opening remarks. Dr. Ruban, do you want to just start briefly in telling us some of the services that you all are doing on the telehealth side and how that's going for you?
Oh, thank you so much for the kind introduction. Thank you for hosting this panel. And thank you to this commission and prior commissions for the amazing work you have done to advance access to care through telemedicine. So our program at the University of Virginia primarily offers specialty telemedicine services, and then post-public health emergency, we scaled to offer primary care telemedicine in a direct-to-consumer format, behavioral health services, which we've been doing for a long time, virtual urgent care, remote patient monitoring, e-consults, Project Echo, and we have used the funding from the commission to scale very massively the services that we have offered. So thank you so much for the introduction, and thank you for the opportunity to join this panel today.
Absolutely, thank you. Why don't we go next to Dr. Ricardo Munoz?
Yes, hi. Thank you very much for the invitation and all the kind remarks that you have done and all the work that you have done for us. Well, for us, definitely was a major challenging experience at the beginning after COVID-19, to the point that we're doing before COVID-19 about 40 to 60 consultations per month. But then after the pandemic, about in 2 months after then, we jumped to close to 18,000 consultations per month. So that was a significant challenge for us, how to enable and train all the physicians to do telemedicine. Then we were few of them who were trained doing telemedicine, and then now we have more than 1,200 physicians trained in telemedicine. So what we have done, we have telemedicine services in all areas. Primary care right now, ambulatory specialties too, they use telemedicine. Now we're launching a very unique here in DC school telemedicine program too. We're going to start with 12 schools, and we got a grant from the school services here in DC. We're going to start in 12 schools, and we're going to expand closely to 210, 220 schools to provide also telehealth. We have nurses now in all the schools here in DC from Children's National, but using telemedicine as a tool, we're going to enhance the care of these patients there. Emergency room, medical specialties, and all the intensive care units now, even in ICU, cardiac ICU, and the pediatric intensive care unit. To the point that we're opening now a command center. We 3 times the one that Dr. Atabaki has behind her, is just to enhance the care of our patients, that we can perform close monitoring of all our patients in the CICU. We have 26 beds cardiac intensive care unit, and that probably will be the first one in the world of this nature. We're going to also provide telemedicine to other countries now. We're doing with Brazil. Now we're going to start also with Uruguay, Colombia, and Uruguay also we're doing telemedicine, and with other centers in the United States too. Also, we are on direct to consumer, who Dr. Atabaki has been pioneer on that. And Shireen, you can mention a little bit of the direct to consumer program for our institution.
Certainly, thank you. We're very excited to have been part of the FCC COVID-19 telehealth program, a recipient of that award, and we're really able to utilize the resources, including the telemedicine platforms supporting care, to quickly expand our direct-to-consumer ambulatory telemedicine services. Very rapidly being able to basically license and train all of the providers, clinical care providers throughout our organization, over 1,000 providers in telehealth within the course of 2 months, as Dr. Munoz mentioned. And pre-COVID, we had about 2,000 direct-to-consumer visits over a 4-year period. Post-COVID, to date, we've had over 110,000 direct-to-consumer visits. Very successful, moving into the community, and even being able to deploy remote monitoring devices like blood pressure cuffs to continue some of our interventional clinical trials. We have a really important one, for example, for behavioral health, treating parents of children with ADHD with behavioral therapy and medication. And it was essential to have blood pressure cuffs to monitor their blood pressure. These medications cause side effects, and we would not have been able to do it without the program, where we were able to send them blood pressure cuffs, and they were able to digitally monitor their blood pressure and enroll and continue in the trial. So very exciting.
That's great. Dr. Robert Donald, do you want to offer a couple words?
Well, good morning. First off, I really thank you for hosting this meeting here today, but I also want to thank the FCC for their rapid and their very forward thinking as we approach the COVID, because without your work, the implications of the pandemic, I think, would have been far more severe. And I really appreciate your efforts to that end. We've heard a lot today about where people have implemented telehealth. We have been very fortunate and great people who have helped us reach out both in the ambulatory world, where we see both primary care and specialty care being offered by telehealth, but we also see it in the acute side and the inpatient side as well, where specialists who, particularly during the pandemic, the difficulties traveling, the lockdown of hospitals, the lack of availability of getting to various places, we could extend the resources across platforms, across organizations. I think another important point, and we're particularly fortunate, we're talking about the ability for geography as a limitation, both short-term and long-term, where telehealth can break that down. But through the FCC and their partnership, we've also looked at the ability to sort of say beyond geography, sometimes it's the social environment. We have people who are in employment. We have people who are in work situations where they can't take off. They're unavailable to do this work. And so what the FCC is helping us to do is to allow healthcare to fit natively into what people's lives are. And I think that that's an important part moving forward. And I think it's one of those things that we really have to drive home. How do we get healthcare natively into something that we do? You know, when we think about providing the care, we also know that there are particular factors in social determinants of healthcare that heretofore I, as a practitioner, I can't have insight into that because I can't go and visit all these people, nor do I have the resources. The FCC is providing us with these tools that, much like the cable box of old, when the FCC and technology companies worked to eliminate the cable box so that it became ubiquitous, that I could actually access these technologies, these entertainment sources. The FCC is actively working on a program here with what we're doing here to be able to make the telehealth such that I can reach out and basically play a role in the social determinants of healthcare, which we know are so important in actually providing that care and helping to avoid cost of care. You had a wonderful example, Commissioner Carr, around the individual who, because of their diabetes. Imagine this work as we move forward into others, such as food security and the locations around the home. Most falls happen in the house. You know, having the ability to go out proactively, look to sort of say, how are we going to care for these patients in an environment that not only is about what they're dealing with today, but how do we actually help them deal with avoiding those challenges for tomorrow? And I think that this is where the FCC has given us very powerful tools in their key ally in helping us to get to the healthcare of the future, not the clinic of the future, but the healthcare of the future.
Yeah, I think those remarks. Yeah, it's quite remarkable. I think I first met Dr. Ruban. I asked her, well, how many different specialties can you do? Because I'd heard a lot about diabetes early on. I think back then she said it was like 70, and I think now it's almost unlimited. And at first the idea in my mind was how do we replicate the care that people get, in healthcare facilities outside. And now, my thinking on that has completely changed. I mean, when you have constant monitoring, you are keeping people healthy. So you're avoiding a situation where their condition drives them to having to go to the most expensive part of the healthcare system, the emergency department. And so the possibilities are endless. I think mental behavioral health is so important. We got a lot of progress to make as a country still, but having access to that, video visits, I think that's been a key driver. I've talked to healthcare providers that say just even seeing the sort of the Zoom background to see sort of where someone's living, how they're living, give some insights to help them on the treatment front. Let's move real quick to Stuart Clary and maybe talk a little bit from the IT perspective of what you're seeing with this ramp up of telehealth.
Absolutely. It's a pleasure. Thank you so much for inviting me to participate today. So very much in context with the FCC funds, which during the COVID pandemic not only helped us develop some technical implementations, but also helped us kind of take advantage of some of the, and this might not sound right, but opportunities created by COVID. So the funding enabled us to purchase a large number of patient exam kits that we have been using in a variety of ways. The platform is called TytoCare. We have been using it. It basically includes a BP cuff, but also otoscopes and stethoscopes, other items that we've been assigning to a variety of patients, started in pediatrics, patients that either have certain chronic conditions, such as asthma. We'll be moving to endocrinology next. And frequent flyers at the ED. I believe you and Dr. Donald mentioned, saving the cost of care before it gets to that most acute, most expensive phase, and working to keep people healthy. And our hope is that for these populations, that will happen. And so that's what we have deployed. We've also deployed a similar project, like in DC, similar to a bunch, excuse me, I'm going to clear my throat. We've deployed these kits to several of the schools in Alachua County who are working with us to keep, especially in areas of greater risk, and to maintain population health among students in those areas, kits to the nurse's office, and they're working back with us. And then finally, speaking, this is more to my heart in terms of what I conceive of the FCC at its core, addressing rural populations. We've been working with our agricultural unit at the University of Florida to set up 13 of their most rural clinical our most rural counties. They have extension offices in them, which we are setting up now and starting to do medical visits, telehealth visits from them. These counties might be literally 5 hours away, and it allows us to move from blockbuster style of healthcare to Netflix, where the patient just has to come in a short while to the IFAS extension location and see a specialist at the university. And it has been, it's a very exciting cross-college project, and we're really looking forward to it. I just also wanted to close with the thought that we have traditionally thought of communications, FCC communications infrastructure being critical for connecting rural populations. I think COVID's presented us with an opportunity to also recognize that telehealth and telemedicine and digital health especially are keenly important in very urban populations as well, to reduce the spread of disease by allowing people to stay home, whether it be COVID, the flu, or somebody who is immunocompromised and at risk from catching something. So I think telehealth is much more than just an implementation for rural communities, but I do think they are a key piece that are going to benefit from these advances as we move. I think COVID sprung us into all recognizing technology and what it can do to facilitate better population health. So thank you.
Thanks so much. As we talk about, ramping up from, zero or close to zero visits to thousands of visits. I mean, so many challenges, practical challenges come to mind to me. Obviously, training healthcare professionals to do this, obtaining the devices, getting the devices out there, making sure patients are comfortable with it. Maybe we can, go back around, maybe start with Dr. Ruban again and sort of talk about, one or two of those, practical hurdles, what you did to solve it, or one that sort of continues to be problematic and difficult. But I mean, it's just, again, just that massive ramp up is sort of hard to understand, particularly when you see it nationwide in the practical work that it took to meet that demand.
Well, thank you. So we had to identify technology platforms that were able to be utilized even at low bandwidth environments, because for us as the University of Virginia, many of our patients come from 5, 6, even 7 hours away, and bandwidth, as you know well, is relatively challenging for some of our rural populations. But that's also true, as Stuart said, for urban populations as well. So again, it was the selection of the technology, and then it was about providing devices to patients. And we've used some of our FCC funding to be able to provide devices to patients that enable them to connect back with us. We also had to put in place models that would, of course, also incorporate bring your own device, because many patients do have devices. And so we had to develop the workflows, train our faculty, the clinicians, the nurses, the staff across the board within our health system, the schedulers, et cetera. Our remote monitoring program, we originally, when we started pre-COVID-19, we were providing devices to patients when they were discharged from the hospital if they didn't have technology to do so. We've scaled that massively, and now we also have to oftentimes mail these platforms and then train virtually once we are able to get the devices to the hands of our patients. So it's a delicate dance, and a tremendous amount of effort and work that has been supported by clinicians and by our information technology teams and our schedulers. It was a very complex process, but it has been successful, and we've been able to do this in significant part because of the funding of the FCC and your vision. Because the first person I heard talk about Blockbuster to Netflix was you, Commissioner Carr, and we are grateful for that vision. Thank you.
Thanks. Another one of the panelists, either Dr. Munoz or others, want to talk about some of that practical side ramp up challenge?
Yeah, thank you, Commissioner, for the question. I think the major challenge for us as we were not prepared for this massive growth. And then when we went from few consultations, less than 100, to thousands of consultations, then one issue is the manpower. I mean, now we have essentially a virtual hospital. So we have outpatients, inpatients. In addition, the regulations and licensing, there is a moving target. So how can we, as with the limited manpower that we have still for this, how can we face, this massive growth? Again, we need to be sure that informed consents are obtained properly. But we're talking about thousands of informed consents. And we're talking, again, the state licensure is changing here. How can we keep up with all these changes? And essentially, every department of the institution should have an attachment to telemedicine, revenue cycle in the virtual hospital, collection department in the virtual hospital, compliance. So I think this is the major challenge that we have, and it's very difficult to be sure that every single consultation from thousands are being done in the proper way. So I think this is the major challenge that I believe we're facing at this now. How we can move from physical hospital to virtualization of care in a massive way.
Yeah, it's interesting. We talk about, becoming basically a virtual hospital. I mean, one sort of question that comes to my mind is, is this something where you take, people that have jobs in the real world, the physical hospital world, and you add it to them a virtual? Is it, you hire a new person for the virtual? Is it, anytime you're shifting from a legacy environment to a new one, there's ways that you would want to do stuff if you're building from scratch, but you're not. You're an existing physical hospital. I mean, so how do you manage that? Again, is it, adding virtual jobs to people that have physical world jobs? Is it hiring new people and sort of walling them off on the virtual side? if you were launching a new healthcare system from scratch today, would it be, easier to incorporate this, harder?
Yeah, I think this is a very important point. And I think the first thing is to convince the physical institution, in quotation, that what are the real needs for a virtual hospital. Do we need to hire more people? Yes, we need to hire more people. We need to demonstrate that we have a proper revenue to support the hiring of more people too. And how can we be sure that we're getting consistently good revenues when everything is changing on a monthly basis sometimes? So I think this is not an easy conversation. However, thanks to FCC, for example, we were able to acquire equipment that the institution were not prepared to invest these thousands of dollars in new equipment. So I think this is the transition that is happening. It's not even in the future, it's already here. And even sometimes I think, should we need a new tax ID for a virtual hospital too? And technology companies, they're investing, other institutions in the nation, they are opening for other companies to invest in technology with our participation too. So it's a whole new world, but it's already here. And I think that's one of the major challenges. I'm also and feel enthusiastic about all these challenges too. But it's a very risky also situation, again, to have this massive growth. And it's just how can we be sure that we are in compliance with all the regulations when we have limited number of people working in this virtualization of care.
Are there others that want to pick up on any of the points there?
This is Bob Donald. I just would like to add, Dr. Munoz, that was very, very powerful insight. I would totally agree. I would offer that, Dr. Commissioner Carr, you had asked about, how do we sort of look at this? Is this a disruptive technology? During the pandemic, we really had to take what we had in place. We had to use people we had available to us. We had to use resources. Let's just take, for example, the waiting room. In the clinic, in those sort of ambulatory environments, we have a physical structure, we have a workflow, we have the people to support. As we move to the virtual, we now had to sort of take those people who were doing tasks, and we had to sort of retrain them in what does the virtual waiting room look like. Those are oftentimes we haven't really thought of. And what happens when a provider is behind schedule, or maybe they're ahead of schedule? How do we manage patients in the virtual environment? We have expectations of many of those who are outside of the actual healthcare delivery, such as third-party payers and such, who are looking at virtual care as being a cheaper form of delivering care. I would offer that the FCC has appropriately and wonderfully recognized that it's not necessarily cheaper. You've helped us to provide the infrastructure that's there, but we do need some help in actually getting the third-party payers to realize that if it's going to be disruptive, and if we're going to move from being transformational to being disruptive, if that's what our goal is, then that continuation of that, building the infrastructure, building those workflows, building the environment so that we move from the operational back to the technical and the strategic around how do we redesign this healthcare, that's still coming, but it needs to be supported.
And this is Karen. I would just like to echo what Dr. Munoz said as well. We could not have done this without the support of the Federal Communications Commission and these funds, because there was limited reimbursement for telehealth services. We didn't have the technology set up. And so this eliminated some of the barriers that we face. And remember, COVID-19 happened, and we had to shut down surgeries, and the revenue models shrunk for hospital systems. So we had to deal with quite a bit. And the commission's funding made such a huge difference for us. And in the Commonwealth of Virginia, we were able to convince our General Assembly to implement payment policies, in part because of the Connected Care Pilot Program. We said, we have these technologies, let us make it sustainable now. And legislation was passed in the Virginia General Assembly, enabling us to have remote patient monitoring as a covered service. Therefore, we sort of come full circle so that we can make these covered services. And of course, as we move forward, and you'll hear about this in the second panel, with alternative payment and value-based contracting, we won't need fee-for-service reimbursement, because it'll be everyday care will be provided, including virtual services. Telehealth is healthcare.
Yeah. How have you addressed sort of disability access issues? Has it been a challenge either from the device front, finding devices that meet all the needs of accessibility communities? Has it been less of a challenge? What are your perspectives on making sure that this, life-changing technology is available to everybody?
So just a quick 2 cents on that. One of the issues that we've encountered has been multilingual support. Being in Florida, we have several large international populations, and as well as needs for like American Sign Language. And so we have been working on making that access as smooth as possible. And it goes beyond just finding a translation platform that will work in Zoom or Teams, whatever the video platform is. It goes into, as we transition, I think, from telehealth to what Dr. Donnell refers to as digital health, the future, where it's all connected. We need to make sure that our EHR patient-facing apps support those languages. And so, for instance, right now, we're able to deploy ours in Spanish, but it's only, if you will, the top level of the app that is in Spanish. The physician is not going to be automatically translated. So I think there are opportunities that we need to leverage there to make this a truly inclusive aspect. And in terms of accessing and using the devices in terms of accessibility, it goes beyond that, because we are handing them out to pediatric populations, and a young child's not going to be able to do an assessment on herself. So we do some kind of guidance and training. We've got video educational materials posted, and we do have a dedicated small telehealth task force help desk, if you will. And so we do try to reach out to patients if they are doing a virtual visit and they have not done one in the last 6 months. We try to contact them proactively and offer a run through prior to the appointment to make sure that we worked out any technical issues or the ability to do it, to have a successful visit. So those are some of the items that we've been encountering, and we're working on it, and we're excited about moving forward. So, again, just thank you for lighting the fire and making this available via the grant funds. And I do think that making it part of, initially maybe fee for service and then transitioning, as Dr. Ruban said, to just part of, the health model, that's where we need to continue to work on.
Great. Any others want to touch on the accessibility, disability access issues on telehealth? Any more perspectives on that?
Yes, that's a wonderful point that you bring up. One of the things that we found is that it's very important to have a multidisciplinary team available for complex care and disabled patients. Having that team available at the same time is always a challenge, but telehealth has really helped improve that. But we have nutritionists on the team, and even our registration teams, for example, have taken on tasks, for example, training families on how to access or better or easy, access the interpreter services, translation services, that kind of thing, which the point that you made, in the future, a whole workforce is going to be needed to sustain this. Really, we had used the decreased in-person volume and the staffing that was somewhat more available during the acute phases of COVID to staff that model and provide that additional support. But now we're going back to our previous volumes for in-person or close to it, and then sustaining high levels of telemedicine as well because of all the advantages it provides, especially in the behavioral health realm. We've actually noticed that patients and families are continuing to seek behavioral health care through telemed at higher rates than they are coming in person, even now with the reduction in COVID cases. And so looking at the workforce needed for that future model and trying to get it has been very, very challenging. So it's a wonderful point that you bring up. And I think a whole new team is required for that, just because of the sheer volume and the needs of complex care patients and families.
Yeah, it seems like we are at an interesting point. With the point you make, you would think, okay, we're a year and a half into this pandemic. We've been doing thousands and thousands a month. Now this is sort of self-automated. It's working. But to your point, now that we're ramping up in-person, physical appointments in hospitals, the quote unquote spare or slack administrative capacity potentially is going back to the older jobs of the in-person world. And so that blending of, okay, how do we do both of these things simultaneously is sort of a new challenge of the present. One question I had as well is on sort of the patient side, the consumer side, and what you're seeing in terms of adoption of these technologies. I mean, anecdotally, again, I've traveled a bunch, met with a lot of you people, but I've heard anecdotally, for instance, that some people have said that older populations, from their perspective, there haven't been as many challenges with them adopting devices and using devices as they would have thought. But again, that's what I'm hearing anecdotally, which is a small portion of the actual real world experience. Maybe touch either on that particularly or more generally what you've seen on the patient adoption. Have there been challenges to people using these technologies, either they want to, they don't, or technical barriers? And if so, how you sort of have overcome those?
I could speak to our remote monitoring program. So we have actually hired patient navigators, actually that predated the COVID-19 public health emergency, to help our patients engage and to train them. We do evaluation of social determinants of health. We enroll the patients in our patient portal. We're an Epic shop, so MyChart, to help familiarize them with how to manage the system. Still, not everybody signs on. But many who do are very engaged, especially when you describe the patient that you saw that you met in Laurel Fork, who herself you would not have thought automatically would have been a great utilizer of telemedicine, but she saw how it really changed her life. And she can proselytize amongst her friends and colleagues as well. We also train family caregivers as well, because not all patients themselves are particularly facile. So family caregivers can be supporters of the telemedicine service for their loved ones. And we offer language supports as well. Some of the platforms do offer the ability for American Sign Language, simultaneous video-based interpretation services. All these things have to be brought into play when we evaluate the availability of services for our patients. And for pediatric patients, equally so, family members have to be trained as well.
Others want to touch on that?
Commissioner Carr, I'll take a moment on it. My clinical practice is largely in older men, large Medicare population. And earlier we heard of the various efforts to reach out ahead of time prior to the visits in order to walk someone through. I think that one of the key factors in whether someone's going to adopt this technology is really their ability to avoid the frustration of making the technology work. It's been said that technology is magic to the uninitiated. And if we can break that down, if we can actually make this something that it works and they engage quite readily, I would offer that a lot of them felt it was very, very helpful. And so when we get there, when we make it easy for them, it's almost like if it was an app on the cell phone, if it was an app on their digital platform, whether it be their computer or whatever, where they push the button and the icon loaded it for them, you could see where it would be much more acceptable. But as they're dealing with the differences in their technology, we would have patients, for example, in which their cell phone may have been an iPhone 6, and I'm not picking on iPhone or Apple, and not choosing Apple versus Android, but those older phones in that patient population who didn't have the money to keep it more current, and therefore it lost connectivity. So as our technology auto updates today and has certain expectations in and of itself, that actually winds up being a weak point in our overall delivery system, because patients would not have been cognizant of that. And I think that if we're going to keep them engaged, if we're going to avoid the frustration, if we're going to make it easy for those populations to use, it is something that we have to sort of make them aware of and see the benefit of. It's an expense.
Yeah, let me ask this. So when you look at patient implementation, obviously we have a lot of devices that go out to consumers, blood pressure monitors, scales. Is one of the ideas that you're seeing that, to the extent you can, are you driving the interface to an app on a phone because that's what people are used to dealing with? Or is that not sort of the default? In other words, is an app on a phone easier for someone to sort of get up to speed on versus, learning the device itself? And so is it, app connecting to devices? Is that sort of one pathway you have found to get people online and using these faster, or not necessarily?
Certainly, it felt like it was much faster and much more successful if they had the right updated platform and an app on the phone.
But it is a significant cost, the data plans that you need to be able to download these apps. Even on my own phone, I keep getting messages that, you have too much on your phone already. So that is challenging as well, especially for underserved populations and families.
And what have you all seen from a connectivity perspective? I mean, obviously there's a lot of challenges. We are doing a lot of work at the FCC to try to finally bridge the digital divide, but we are very far from waving the mission accomplished banner on that front. But I think it's interesting to get your all sort of feedback. It could be anecdotal, but it also sort of is helpful to us. What did you see in terms of connectivity challenges? Was it what you would thought, better, worse? What did you all see in terms of the devices actually working and connecting to the internet?
We had lots of challenges. I mean, there were many patients. I will say, honestly, patients love telemedicine when it works. Providers love telemedicine when they can connect to their patients. But where there's that gap, it's a real challenge for us. And I think it was Dr. Adabaki who mentioned the data plans. I would like to also say, we have to be cognizant of our patient expenses. So if we have somebody connecting through the patient portal waiting to see the provider, we're using up their data plans. So we need to make sure our workflows accommodate the needs of our patients as well. So when patients have had good connections with us, when providers have had good connections with the patients, everybody's happy. When it doesn't work, everybody's frustrated.
And one of the issues that really helped us was everything going to a virtual model. So school going to a virtual model, work going to virtual models, that really automatically trained patients and families for us in utilizing these platforms. So they became much more savvy at utilizing them, and the platforms were readily available. For example, Zoom, a lot of the schools were using Zoom, and it became much easier than pre-COVID. However, I think as that moves to more of a hybrid model and less virtual, more in person, I think they're going to forget some of that training, and those platforms they had set up in their homes on their personal devices are going to go away. So that's also something we need to be cognizant of.
I think once we start expanding the telemedicine to all populations, then we're going to have more connectivity problems. And I think the other aspect that I'd like to mention, connectivity, is the cybersecurity part too. Because, for example, at schools, when now we're trying to develop implement telemedicine in schools, it's going through the firewalls at schools also is a problem. So it's not only providing connectivity, but also secure connectivity. That goes together, and that's another expense. The cybersecurity is completely different. We don't want our schools to be invaded by, not very wise people or not well intended. So it's an additional expense. Everything that we have a connectivity, whenever we have a connectivity, cybersecurity is an issue too.
I just wanted to chip in, playing off what Dr. Donald said about devices and them becoming obsolete, and what Dr. Ruban said about the expense of them. So one thing that I've noticed is if a device is more than I'm an Android person, so I'm not picking on them. I love them, but mine is about 4 years old. And while I can conduct my virtual visits on it and connect all my devices through it, it doesn't allow me to use the latest innovations. So for instance, we're a Zoom shop, and if I had a new version of this phone, I would be able to use Zoom in my virtual platform without downloading a dedicated client. I have to have the dedicated client. It's another step which could represent a point of failure. And so this is kind of a two-sided coin. So on the one hand, our population living on fixed income might not be able to afford the latest phone, let alone the data plan. And schools and universities, especially schools, will tend to buy equipment that's, not the latest model because they could get a great deal on it, and maybe lack the foresight that equipment, because of obsolescence, if you will become not very useful in a much shorter period of time. And so I think there is potentially at a legislative level an opportunity to investigate, do we want to set certain standards for a device in terms of X months or years that it would receive the latest updates? And that might help us as a nation standardize, be able to kind of better address some of these connected care and digital health challenges.
At what point do you all find out the end user device and sort of what it is and what its constraints are? And does that sort of, go into a patient database and you make decision of what you can do based on that, or when is that determined?
Well, right now, we get that from the vendor, the manufacturer. So typically that's going to be Apple, and it goes down from there. It's manufacturer based, not platform based. So Samsung can choose to update its version of Android or not. And we are not publishing that list at the moment to our patient base, probably because it might be very confusing for them. Less so on the iPhone side, but on the Android side, there's a whole spectrum of devices and ages. And so to have an exhaustive list like that is both challenging, and I don't know how effectively it would be leveraged. So I think the idea would be that if I had a phone and I knew that it was less than X years old, I would be good to go. And that would be very easy to publish on our site. That says your phone has to be, from 2015 or newer in order to work. Right now, to take full functionality, it would be from about 2019 or newer to completely work. So I think that is an opportunity to look at a little closer.
Great. Well, we're nearing the end of this first panel, and I want to, go around the horn one last time and give each of you a minute to sort of offer any other thoughts you have on the practical side, the successes you all see. And again, I think the idea for this panel, for this whole event, was from meeting with you all individually and hearing, one-off, challenges and opportunities. That'll be a good start of a conversation to hear directly from you all. It's been helpful for me to hear about, the practical challenges from connectivity, data plans, getting customers and patients used to using these devices. So it's been very helpful to me. And obviously, I think, express my appreciation to America's healthcare heroes. I mean, just the idea that you all ramped up so quickly is remarkable. I mean, heck, even our toilet paper industry couldn't meet the increase of demand because of COVID very quickly. And that's a lot less complicated than ramping up telehealth. And this is something that we are going to be, partners with you in. As a lot of you said, we've been active in telehealth for quite a while. It used to be just supporting connections to brick and mortar facilities. Now we're moving out here into remote patient monitoring, connected care, as we call it. We want to be good partners with you, and this is a way to do it. So maybe real quick, we can go around the horn with 30 seconds to a minute of the panelists with some closing thoughts.
Well, I'll start. I'll say telehealth is here to stay. Virtual care is here to stay, and it's going to be a matter of right sizing. All of our institutions are looking strategically at what's the right role for telehealth services and virtual care. But also, it'll be really important as you lead into the next panel that we align public policy, reimbursement strategies and approaches both at the federal and state level, because these investments will need to be continued. We need to have our patients connected. And I do believe, again, telehealth is healthcare. It needs to be right sized. We need to have the workforce, and we need to have alignment across all the federal agencies and our states to make it a consistent, cohesive mechanism to provide care to our patients. And thank you for your work and your vision.
Thank you very much, Commissioner. Again, and I think the most critical part here is don't leave us alone. We need this partnership 100% because we are on the critical point of growing now, and we have done very good things now, but we don't want to do bad things. We need to, again, to transition into this growth and be sure that it's safe for our population, and again, that we can expand in the best way possible. So we need your support. That's all that I want to say. Thank you. Thank you.
And this is Bob Donald. I'd like to offer, I'd like to build upon that. I agree with everything said. I would like to also offer that beyond even just the primary care or that health that we see on the routine basis, chronic disease and such, telehealth represents probably the greatest opportunity to provide equal access to quaternary and tertiary care, which is heretofore the future, if you will. How do I get to that specialist in Boston who may provide a type of heart care that I can't get in my local community, and get that sort of specialty so it's available to me? And so with your help and with CMS's help, how do we break down the barriers of state and insurance and geography in order to say that healthcare across this country should be a uniform delivery of quality and safety that provides the healthcare outcomes that we're looking for?
Stuart, do you have a closing remark?
I'll just echo what Dr. Donald said, and also that thank you very much, Commissioner Carr, for getting the telehealth fire lit. And we look forward to making it, transitioning it hopefully over the near future from a kind of grant-funded support to a sustainable support. And as Dr. Donald implied, integration into a larger context of digital health. And thanks very much for having us today.
Great. Dr. Adebaki?
Yes, thank you very much for your support. And we're very excited to be able to really be part of the future of healthcare and developing this virtual hospital, and really also making sure that we reach the digital divide, which to date, again, with the support through the FCC and in kind from a lot of our organizations, we've been able to do and go to models where the majority of our patients receiving telehealth are actually publicly insured. So very exciting. We want to make sure we can sustain that in the future. But thank you for your support, and we're looking forward to the next phases of the Connected Care pilot program to really look at making sure healthcare into underserved communities continues bringing excellent care to patients and families right at their bedside, no matter where they are. Thank you.
Well, thank you so much to the first panel, and we'll do a quick panelist swap out. And while we're doing that, I'll introduce the next round of panelists. Again, some great healthcare providers that I've had the chance to spend time with at their own facilities. Dr. Tiersany Davis, who's the Director of Clinical and Advanced Practice Operations at the University of Mississippi Medical Center. I know a lot of people are probably sick and tired of me telling my Mississippi telehealth stories, but really the mustard seed for so much of what we're doing at the FCC, at least on Connected Care, goes back to time I spent with University of Mississippi Medical Center team, including up in the partnership that they did with North Sunflower Medical Center up in Ruleville. Next up is Dr. David Houghton. He's the System Chair of Telehealth and Medical Director of Digital Medicine at Oxnard in Louisiana. I had a chance to spend time with him and his team down there maybe 2 years ago or so at this point. Next is Deanna Larson. She's the president of Avell eCare up in Sioux Falls, South Dakota, although I had the chance to testify with her as well recently here in Washington, D.C. I've also spent a lot of time with the Avell team. I have a hard time. I always think of Avera, the former name, both in Sioux Falls and actually, the other end of that connection, all the way in the Pine Ridge Indian Reservation in the southwest corner of South Dakota, and seeing the connection back to Sioux Falls and how that technology is delivering life-changing care to a community that is many, many hours away from the big city in the area of Sioux Falls. Dr. Trujillo, the Chief Medical Officer of Banyan Community Health Center, had a chance to spend some time down there in Banyan in Florida a couple months ago, see the good work that they're doing. And finally, Joel White, who's the Executive Director of Health Innovation Alliance, who has some interesting perspectives on a lot of the issues that this panel is going to look at. So as was sort of noted, this panel is going to look, obviously some of the practical challenges we are free to discuss as we did in the last panel. But one of the things that I wanted to broaden out with this panel was some of the licensing and reimbursement issues. I think one reason why telehealth has been so successful during COVID-19 is a lot of the early waivers of some of the licensing and reimbursement issues including some HHS waivers, which are set to expire or sunset when the COVID-19 pandemic declaration goes away, if it ever goes away. We'll see. It's a separate conversation. And we really cannot afford to go back to the status quo before COVID-19 in terms of where we were with licensing and reimbursement. And to some extent, we're already seeing some of the problems that are coming from unwinding of some of the permissions that took place during COVID-19. And there's a Wall Street Journal article a week or two ago about patients in one state that were seeing a specialist in another state, and that's already starting to drop off because of some licensing and reimbursement issues. So I think this is too important of an issue. We cannot allow regulatory red tape to stand in the way of the continued success and growth of telehealth. So I'm looking forward to this panel talking some about that. So why don't we start with Dr. Davis, and we'll just go through the panel, maybe just giving us a brief overview of what it is that you all are doing in telehealth, and we'll sort of build from there.
Hello, everyone. Can you hear me okay? Okay, great. So yes, we are part of the University of Mississippi Medical Center in Jackson, Mississippi, which is the only level 1 trauma center, the only academic center in the state of Mississippi. We've been doing telehealth officially since 2003. And that started with our telemergency program, and that program is still very successful. We've also expanded to include many specialty services via telehealth. I won't list all of those, but if you can think of it, we're probably doing a little bit of it, at least. We have a teleurgent care program, which is our direct-to-consumer program. Thankfully, we were doing that before the pandemic, so it put us in a great position to be able to respond to the pandemic. We have a behavioral health program and also remote patient monitoring. And Commissioner Carr, you got a chance to visit one of our partners with our remote patient monitoring program and even talk to some patients, I believe. So we do have a pretty comprehensive program. One of the great things things that we're very proud of is our ability to respond during the pandemic very early on, and our work with our Department of Health, to assist them in identifying patients who are at high risk for COVID, connecting them to testing, and ultimately connecting them to vaccinations now. So we're very happy about that.
Great. Dr. Houghton?
Thank you, Commissioner Carr, and thanks to all of our colleagues here who are on the call today this morning. It's my pleasure to be able to join all of you and talk a little bit about the experience that we've had down at Ochsner Health in the heart of the Gulf South in New Orleans, and with many of the same problems that we see with our friends over in Jackson as well. And so Dr. Davis and I are good spirits together in the work that's been done in telehealth. Down in New Orleans and in the surrounding regions in Oxford, we have more than 200 connected clinics that are able to see patients in a bricks and mortar fashion. And our telehealth program really started about 20 years ago with hospital-based programs like telestroke. And as Dr. Davis had mentioned, similarly, we had built the platform in two major ways. One for those forward-facing visits in a hospital, in a clinic, or at home, at work, on vacation, or at school, but also in our remote patient monitoring space with the birth of our Innovation Ochsner Suite more than 5 years ago, to be able to manage things like diabetes, hypertension, now lipids, COPD, and other programs coming down the pike. And so we were prepared, and yet no one could have expected what was going to happen to us almost 2 years ago, to the tune of now almost 350,000 virtual visits that were done in that first year, more than 200,000 this year already. And so while we've had significant maintenance, as Commissioner Carr had mentioned, there are changes that all of us have benefited from the public health emergencies, things that we've recognized where unique value was able to be gained, particularly in many of our vulnerable patient populations. Medicare and Medicaid are some of the ones where we've seen unique and much larger than anticipated uptake. More than a third of all of our visits in telehealth are through our Medicare patient population. Our Medicaid patient population takes up about 15% of those. And it's the largest growing segment, our Medicaid patient population is, of those that are enjoying the benefits of our programs in the digital medicine space for hypertension and diabetes, much of which would gain the advantage of 2 rounds of funding through the FCC to take away much of the extra costs for our most vulnerable patients. So very pleased to be here. I'm looking forward to talk about the wins and some of the ongoing challenges.
Great, thanks. Deanna Larson, good to see you again.
Yeah, good to see you, Commissioner Carr. Thanks for the invitation today. And as Commissioner mentioned, actually he has known Vera eCare for as long as he's now known Avel, but which really helps me introduce who we are. Avel now is a spin out of a not-for-profit going into a for-profit, but we're still a provider of care. And our major focus is to augment care. We're in 650 different locations and we're in 34 states. So we often aren't the primary provider, although we can serve as that if the orientation of the organization needs that. But typically we're augmenting. Augmenting in Texas as a matter of interest. We're from South Dakota as our initial hub, but now we have a hub in Texas and one in Michigan. What's really important to think about as an example, we've watched COVID now second or third, whatever you want to call that, move across the nation. We augmented in Florida. There was actually EMS giving in patients' homes, giving the IV infusion, the monoclonal infusion. We watched telemedicine, the 45 minutes last part of that individual, keeping them out of those very busy hospital locations. But we are an organization that supports acute care. We have ICU, e-hospitalist, e-emergency in the acute care sector. And in the ambulatory, we support nursing homes. We have school health. We also have the multi-specialty clinic and behavioral health. So our purpose is really focused around workforce. So we think of ourselves as a workforce solution, really augmenting critical access facilities, regional community hospitals, and importantly, understanding the work of tertiary and quaternary care centers, how to keep that ecosystem, if you will, where patients really within any given location, there's that, where do patients need to transfer, or where could we help support and augment care in a smaller location like critical access. As a matter of fact, that is where most of our focus is rural, and that's where Commissioner Carr has really been so influential and helpful in making sure that the broadband was available in those locations, supporting those USAC and FCC funds, as well as some of the hardware that the most recent funds helped put in those rural locations. So we're a little bit different than the academic center, but our goal here is to really retain and support care. And yes, we have a lot of issues that we'd love to talk about today.
Well, one of the things I love about the Avel eCare, particularly the facility I've been to a couple times now in Sioux Falls, is it's basically, sort of a warehouse type environment. And you go inside this connected building, you've basically recreated a sort of a high-tech emergency room in there. And then sort of virtually what you do from there is you feed into small rural hospitals. So when there is an emergency or specialty care needed, you basically can beam that specialty in virtually from Sioux Falls. I think it's a great model, and it's really helping to improve health outcomes. Dr. Trujillo.
Hi, I'd like to thank you, Commissioner Carr, for inviting me to this, but most importantly, I'd like to thank you on behalf of the patients that we are able to reach and serve through telehealth. One of the things that the way that I look at the practice of healthcare is there's no reason for any healthcare provider to exist if the patients did not need the care. And through the years prior to COVID and through COVID, these patients have been part of the no-show rate is being very, very high. And telehealth has actually dropped this no-show health rate, allowing us to provide care. I'm the Chief Medical Officer for Banyan Health System, and we provide health care to primary care patients, behavioral health, and substance use disorders. We have a detoxification unit and a crisis unit. And one of the major things that we have been able to identify is to be able to reach through the intensive telehealth unit, thanks to the FCC grant that we were awarded for those patients with diabetes and hypertension, but complications with depression and post-traumatic stress disorder and pregnancy issues through telehealth. Not only have we been able to do that, we have actually managed to get some of the insurance company to approve services for telehealth, to the point in which I'm happy to announce that one of the third-party payers today approved one of my crisis patients being discharged today to have an approved telehealth pay visit in a week, which is a requirement of healthcare providers. And prior to this, I had to get this patient to come back to the unit to be seen for and evaluated. And guess what happens when you just get discharged from the hospital? You don't want to go back to the hospital within a week. So they became the no-shows or the missed opportunities. The other thing that we have seen with telehealth is in the substance use disorder population is the fact that we have been able to effectively prevent overdose prevention because of telehealth that takes place on a substance abuse patient that would have missed his or her appointment anyways because they were intoxicated or getting high on drugs. We're able to intervene, send help, and stop an overdose on the way and the process. So one of the things that I think is going to be the extension of our capacity to provide healthcare through telehealth is going to continue to improve and grow.
Great, thanks. Joel White.
Well, thank you, Commissioner Carr, and for all the efforts of the FCC to expand telehealth. My name is Joel White. I'm the Executive Director of the Health Innovation Alliance. We were started in 2007 as a diverse coalition of healthcare providers, patient groups, employers, insurers, and tech companies who support the use of technology and data to make healthcare work better. And one of our top priorities is to improve care by expanding telehealth. And I think what we saw during COVID was exciting, and it changed everything, right? We saw it change the willingness of doctors and hospitals to deliver care at a distance and to monitor patients remotely. I think we saw a change in consumer attitudes in terms of using telehealth in their homes to access care and perhaps avoid dangerous situations where you had COVID-infected patients. And at the same time, we saw a willingness on government to change some silly rules and institute new programs like the FCC programs to expand telehealth. And I think what we saw is nothing short of remarkable. We saw a 62-fold increase in the number of Medicare patients accessing telehealth care in 2020. That's 52.7 million visits just in 2020. That was a big result of changing those policies. And the other thing we've seen is that an incredible use of telehealth in the behavioral healthcare space. We have a number of behavioral and mental health patient organizations that benefit directly from telehealth services, including the FCC the FCC Connected Care program. And that's delivering real care on the ground. As much as 70% of those telehealth visits for behavioral and mental health issues were done audio only. So this is having a real impact for people on the ground, real patients on the ground, and the providers of services. And so we think that your enthusiasm for telehealth is well-founded. I think it's transforming care today, and it can transform care tomorrow. I noted your comments that we're never going to go back. We hear that every day from members of Congress and their staff, and yet the telehealth flexibilities and what's really spurred on telehealth adoption will go away when the public health emergency goes away unless Congress acts. And so we need them to act. We need the FCC program to be tweaked a little bit. We need to address interstate licensure and make a number of other policy moves that will really, really kickstart and accelerate the revolution that's occurring in telehealth services. Thanks for letting me be here today.
Yeah, thanks for your words. You're exactly right. We say we cannot go back, but we very much will go back unless we pass some legislation to make sure that we don't. I know there's some bills in Congress right now. I testified about some of them that could do this. Maybe for the uninitiated on the healthcare side, could you all describe what it was that changed from a legal, regulatory perspective at the beginning of the pandemic and why that made such a difference? I don't know which one of you wants to tackle that first.
I can take. Oh, sorry, go ahead.
Yeah, I was just going to speak to our ability to see more patients in their homes. That was a pretty big deal, and also for our providers that had not quite bought into telemedicine yet and were not comfortable, with the video conferencing, or maybe it wasn't set up and we needed time, to implement and to do training. Our ability to see patients or to take care of patients using audio only was helpful. In Mississippi for so long, we argued against audio only because we didn't want people to choose that, as a first line of diagnosing and treating patients. But the pandemic really gave us an opportunity to show how having that audio only option actually helps. It adds to. We still see video conferencing as our preferred method, of truly assessing, diagnosing, and treating patients. But audio only is very helpful as well. And again, I say our ability to see more patients in the homes, particularly with Medicare patients. Those were the patients that needed it the most. Those were our elderly population or those who are disabled or had other comorbid conditions. So we really needed to keep them out of circulation in our hospitals and definitely in the ER at that time. So the expansion of the sites of service that were reimbursed for telemedicine was really helpful for us.
I'll jump in there. I think that, the big thing was that we have these silly rules in Medicare that were created decades ago. And some of those rules say that you can't get telehealth in your home. You've got to go to an originating site like a hospital, a physician office, clinic. You have to be in a rural area. And yet we know that there's a lack of provider concentration in urban areas. And sometimes transportation issues are very difficult. And so access to telehealth in an urban area is just as important as in a rural area. Those two requirements were waived by Congress and CMS as a result of the public health emergency, but they'll snap back into place once the public health emergency is over. The third issue is that reimbursement was increased to largely be on par with in-person visits. And that created a financial incentive for a lot of providers to do the service. And the fourth thing is that there was some flexibility created around interstate licensure, even though some providers still had to go state by state to get state legislators to make some tweaks to ensure that facilitated interstate licensure supply of telemedicine. But I think the big thing, if this snaps back, if we lose these flexibilities, we won't see the investment that we need to see, because the certainty in provision of telehealth services could go away if we go back to the old way of doing things.
Yeah, from our perspective down in New Orleans, it's identical to what Mr. White and Dr. Davis had mentioned. Those were the major ones for us. Just a couple other to add on. I think some of the expansion of telehealth services beyond what was previously defined is mostly physician-based services, but also other allied health professionals like occupational therapy, physical therapy, speech therapy, et cetera. I'm a practicing neurologist, takes care of patients with Parkinson's disease and Alzheimer's disease. And for all the things that we've heard so far, to be able to see those patients in the home and then be able to get them additional services that are so critical for their health and wellness is an important thing. And the other thing is on the remote patient monitoring service, the waiver of the copays that are associated with those services for our Medicare recipients is another very important waiver that we've seen, and one that we would like to see permanent. Upwards of 20% of patients with Medicare do not have a supplement or something to cover those copays. And so they bear, in many circumstances, on a fixed income an excessive burden for something that is really showing significantly long-term benefits to not only improve their health and wellness, reduce things like heart attacks and strokes for the individual patient, but also for the health systems and for the payers to know that there's going to be fewer ER visits, there'll be fewer urgent care visits, there'll be fewer utilization of high-cost sites. And so to see those waivers become permanent, we think would be really important for sustainability too.
Gotcha.
I agree with the whole team. The whole point here, CMS has established rules that are archaic and with no expiration date, and technology is here to stay, and technology is moving forward, and yet CMS regulations have not moved forward, and it is affecting our capacity to provide the same care that I would provide face-to-face through the use of technology. And technology is not considered as a possibility. So it's actually a setback in the healthcare department.
May I add something really quickly? When Dr. Houghton mentioned the copays for remote patient monitoring, we're right here, in the middle of December, and we're having to look at our patients that are on remote patient monitoring and prepare ourselves for conversations with them about the deductibles restarting in January. And that's a big deal, when you think about the variability in how much, patients are having to pay for these programs. So we are expecting, several patients that need to remain on the program to make the decision that they can't continue, because of copays. Now, thanks to funding by the FCC, we'll be able to keep most of those patients on the program. But, just think if we did not have that. So yes, we are very appreciative of the funding that you give us, because it allows us to make a case, for going back and making policy changes. But I think that sometimes those who make the policies, don't think about the implications of giving back someone something and then pulling it back. In our program, we often say it's better for us to not do it at all if we don't think that we have a plan, for how we will be able to continue this. So that's a pretty big deal, because we are then creating an additional disparity, in an effort to reduce disparities. It's going to be between the have and the have-nots.
When you look at the outdated nature of the regulatory and legal framework, if you're sort of describing blame for why that is it simply, regulatory inertia in the sense that this made sense 20 years ago and doesn't today? Or is there sort of fear among some stakeholders that if we open the door to this, there'll be abuse of it, it'll be, net requiring more expenditure? Because all the data that I see, points to the fact that, there's even when you have to invest more money in telehealth, these savings on the back end, actually monetary savings, obviously in addition to patient outcome savings, are just significant. And so if you were sort of say from your perspectives, why have we failed to update it? Is it just made sense and there's just regulatory inertia takes over, or are there sort of stakeholders that are sort of pushing back and saying, no, don't open the doors to more telehealth, we're worried about X or Y?
Well,
So I'm sorry. Go ahead.
But that's fine. Yeah, I would start out with, I think it's both. So first of all, I think it's outdated, and if you read many of the policies or the regulations, if you just inserted telehealth with an inclusion statement, it would be helpful. That it just wasn't thought of 20 years ago. I've been in telehealth for 20 years and kind of been fighting and bumping up against these. So certainly, what happened with COVID opened the door. So our opportunity, I think, with all of the panelists that you've heard, is the huge volume. You talked about the long-term savings. So, early care, early intervention reduces all of those, that spiral of illness that happens that lands many individuals in the hospital. So if we take away all of the things that were early identified as a result of COVID, all the flexibilities that were offered, we're going to hit that cliff, and those same people who spiraled before will go back to that disparity issue that was so eloquently spoke of. So I think part of the challenge we have is, can we get some good analytics of the data? Because they are longitudinal. It is a longer term impact from a financial perspective that we're really impacting by early intervention. And, having been in this for 20 years, our numbers were small. Commissioner Carr, coming from the middle of, the Midwest and small volume, but that's not true anymore. We should be able to do analytics on the data that's collected in all of these individuals represented here to prove that we've saved dollars by reducing complications of illness that were intervened by telemedicine.
Can I add to that? So I'm going to throw a couple Washington terms out here because I'm in Washington, D.C., and hopefully it makes sense to some folks. I think what we saw during the pandemic was 92% of telehealth visits in Medicare were in the beneficiary's home. That wasn't possible until the regulatory flexibility was created, because 1834M section of the Social Security Act says that the beneficiary cannot get telehealth services in the home. So it's the law that constrains the provision of the services that was flexed up during the public health emergency. So it really requires Congress to change the law. So why haven't they changed the law yet? Well, the answer is the scorekeepers have said that doing so will be very expensive, anywhere between $50 and $75 billion to create this flexibility. The reason they think it's so expensive is that they believe that telehealth services will add to rather than substitute for in-person visits. And what we see in the data thus far is that is not the case. There's a clear substituting out of telehealth services for in-person care. Nowhere is this more evident than in the behavioral and mental health space, where we see upwards of 90% of claim volume being done virtually versus in-person care. Now, we can argue about whether that's good or bad clinical care, but you can't take 90% of those visits and put them into telehealth and say that that's all additive. There's clearly a substitution effect going on. So we need to address the scoring. we're doing a study right now with IQVIA looking at invoice data in 3 specific instances: primary care, cancer care, and behavioral care, and trying to get some arms around what's happening on the cost side as a result of these flexibilities. But it's the cost issue. It's really constraining Congress from moving forward rapidly.
And I'll add in that there's other opportunities where you actually see a cost reductionism, right? Not just not the add-on and not just the replacement of, but actually because of particularly remote patient monitoring programs that you're able to reduce face-to-face touch points either virtually or in person. And so when you really are able to look at where the speedometer is going there, it really ends up going in the opposite direction in a favorable fashion for all the payers. And so I think my colleagues have hit the nail on the head here. It's mostly cost and fear related to those costs.
Absolutely. The sad thing, and Joel mentioned it earlier, was, if we reverse these things that are in place now, we will not have fully realized the impact, that these waivers and things have had, on our ability to serve the patients. Some things we learn right away, like, right away, if you have reduced an ER visit, or if you have, cut out an extra hospitalization, those kind of things we can see pretty soon. But when we really look at the long-term effects of having telehealth available, that can take years. To see that, especially in a patient with a chronic illness. Remote patient monitoring is going to help, and we will be able to say, yes, they had access to a nurse that was helping them, that was coaching them. We are seeing reductions, in their A1Cs. But what about the reduction in the number of medications that they're having to take? Things like that are going to take time. And, 16 months is really not long enough, to really see the impact that telehealth is having.
It's interesting. When we first started talking about this connected care program back in 2018, one of the ideas for the program was to help prove up this point, or hopefully prove it up, that connected care net drives down costs in the healthcare system. And I still think that's an important goal, but now we've got so much more evidence with COVID-19 of all these other programs that we definitely need to collect, obviously, this data, package it together to help make the case that this is a significant net reduction in expenses. One other point I want to touch on, and I think this was something that I tried to learn when I was on a visit to Oxnard, but I don't think it stayed in my brain. I'm not a healthcare person. I'm barely a broadband person in some people's minds. But you were talking about the different healthcare sort of payment structures, fee for service. Maybe sort of remind me again what those are. And I think the idea, at least as I understood it, was there are some forms of care, I don't even have all the terms right, but that are better line up from an incentive structure for delivering telehealth services versus others. Maybe some of that has changed in light of some of the upping of reimbursement and some of the waivers. But maybe, David, maybe you can sort of remind me about that and sort of how some of the incentive structures do or don't fit with telehealth.
Yeah, thanks for that. It's a great question, because when you really think of a care ecosystem where you're trying to hybridize in-person care where appropriate to telemedicine in a forward-facing episodic fashion where appropriate to a back-channel remote patient monitoring program to keep patients well and keep them out of your system, what you discover is that there is a different payment model across different payers, across CMS, and across others, and by others, we mean even employers who want to contract with you independently to take care of their employees. And so what we realized during the PHE is that, and I think Joel had mentioned it, that some of the forward-facing telemedicine reimbursement was in line with what you would see in an in-person visit. And that makes sense under the vast majority of circumstances. But if you're monitoring someone on the back end in a remote patient monitoring fashion, some of that code is written, or those codes have been written to sort of still utilize this fee-for-service mentality, which is the number of minutes spent on the phone or the number of interactions. And in fact, if we're doing our job well, that will get lower and lower and lower. So we sort of work ourselves out of a fee-for-service model. If we have a patient who's in control with their diabetes and hypertension, and as Dr. Davis mentioned, we are hoping that over the next 18 months, 5 years, 10 years, they have fewer heart attack strokes. We may actually be unreimbursed or more lowly reimbursed than for a patient for whom we decide to just tack on a visit, because then you would get your 20 minutes or your 40 minutes, et cetera. So the reality is if we can pivot to what we've tried to do in many value-based models, whether it be capitated care models or others, I think there's a huge opportunity to where we think about this healthcare ecosystem that really melds forward-facing telemedicine with back-end remote patient monitoring with in-person care where it's necessary into something that makes sense going forward. And I welcome others to agree or disagree for sure.
Well,
I agree.
one place we're really finding this as an advantage would be our skilled nursing support that we provide. So many of those have managed care organization residents within them, someone who is being, really not Medicare managed anymore. It's another organization or an accountable care organization. So those individuals typically into those skilled nursing facilities may have someone visiting that facility, maybe a nurse practitioner, but they can't be there 24/7. And, all of you know that when a elder becomes ill, it's a quick spiral. You can't wait until someone can either be, call and take them to a clinic, or, most of them haven't been allowed, out of their buildings for a long time, if you will. So being available on telemedicine for them and really helping to reduce those costs that were really talked about, either to the clinic or to the ED. But in an ACO or MCO managed care organization, what we're able to do is through telemedicine, really understand the acuity and improve the acuity coding, if you will, so that that skilled nursing facility gets the right level of reimbursement for that individual, and really has the care being provided in that skilled nursing facility versus taking them out. So it's a great example of, those who are already taking a risk, if you will, those third parties, the accountable care or managed care organizations, where we as augmentation to that, we take that risk with them to reduce those ED visits, to reduce those extra visits or hospitalizations, really keeping their nursing facilities, at as full as they can, which really helps their economics. So it's really thinking about that network that can really work collaboratively with whomever is already providing and accountable for that care, but supporting them in that provision of care when they're not able to be there. That at-risk piece, I think, is what's really interesting, that we could go at risk or others could go at risk, because we've proven, and all of you on this call have proven, that telehealth does reduce costs. So maybe we need to have those programs making us more eligible. There are some out there, but they're difficult to get into. Having programs like that more eligible to us to take risk on those types of individuals. And those could be at home, obviously, as been mentioned here, as well as in a skilled nursing facility.
And I might not be catching this right, but is it fair for me to say, and I could be mixing terms here, that fee-for-service models line up in the least telehealth-friendly way, and that capitated and other value-based mechanisms line up structurally better, or have I botched terms that are outside my expertise?
I think we are saying that, there are definitely some telehealth programs or models that fit better, in the value-based arena. And I think that remote patient monitoring is a huge one, because I can tell you over the past few years, we've spent a lot of time trying to decipher these codes and what they say, needs to happen, in order for us to get paid. And it's a pretty hard sell, to even, primary care providers who need to be referring their patients, to remote patient monitoring, because they're not being managed, very well. But they're thinking, okay, what's in it for me, number one. And then on our side, we're looking through, because of the cost, the cost of equipment, the cost of what it takes to run these programs. We're having to say, like once one of our colleagues mentioned, okay, for each patient, we'll probably talk to them, X number of times, so that we can, and then how do we appropriately track that? How do we make sure that we're getting paid for our every 20 minutes? All of these types of things, when we really just want to take care of the patients. So if remote patient monitoring could be a part of the whole value-based system, that would be a whole lot better than us having to kind of nickel and dime our way, through making sure that we get reimbursed for everything that we need to get reimbursed for.
It strikes me that the VA has been on the leading edge of a lot of telehealth. Is that in part because of what we're talking about here in terms of the incentive structure and how payments work, or is it a separate reason?
I think it's twofold. I think the first thing is it's a closed system, right? So they can kind of control what happens within their system. And the other thing is that they had a strategic decision many years ago to really incentivize telehealth care because we had veterans who were living in very diverse communities, and access to bricks and mortar VA facilities was very difficult until recently when we expanded things out into more of a choice model. But I think that, from the fee for service standpoint, right, like I get paid every time I do a service. That's fee for service. In these value-based models, what it says is I get paid maybe a capitated amount, maybe $1,000 per patient per month, let's just say. And if I do more within that model, it costs me more, and that means I keep less of the difference. So what we need is really a blend of the two, where if I'm in fee for service and I'm driving down costs, I want to share in the gains or the savings that I make in other areas, the ER, the hospital, the physician office, et cetera, so that really, because most Medicare beneficiaries are in fee for service, that's where we're going to have the biggest impact in realizing and capturing some of those cost savings.
Is this from a DC perspective? Is this sort of, we need a thumb on the scale? Again, I'm not a healthcare person, so I don't know if I'm gonna get like a swarm of paid lobbyists banging down my door. But is this like we need a thumb on the scale against fee for service? And is that sort of the way that we sort of fully and further tip the scales towards telehealth? Or is it overstating it to say that, we got to put a thumb on the scale against fee for service in order to sort of continue this evolution towards telehealth?
Fee for service is a really outdated model. It was created in the 1960s in Medicare because that's how care was delivered back then. Since then, we've already tipped the scales, put the thumb on the scales a little bit by saying that Medicare Advantage, or the private plans that deliver comprehensive benefits in Medicare, can deliver telehealth services as part of their base benefit offering. In fee-for-service, what we've tried to do, starting with the Affordable Care Act and the Obama administration, was try to transition fee-for-service into some of these more value-based models like accountable care organizations and medical homes. And the challenge with those is that outside of accountable care organizations, if you're a value-based model in Medicare, you're still constrained by the same fee-for-service rules that govern telehealth. So we need to say that any risk-based model or any value-based care model in Medicare, you should be allowed to use telehealth however the heck you want, because you're at risk and you share in the efficiencies if you use whatever delivery system you want, whether that's in-person care or telehealth. So I think we need to continue tipping the scale away from fee-for-service into these value-based payment systems and into Medicare Advantage.
And then what is the long-term vision? I mean, obviously the FCC has multiple programs now. Our traditional program that we connect to brick and mortar facilities, connected care, emergency, COVID-19. These are, some of them are appropriated, some are from our Universal Service Fund. My personal long-term view is that, the injection of FCC dollars, particularly the connected care program, which is basically taking, assessing portion of someone's traditional telephone bill. That's how we get the money for our Universal Service Program. And then we do a lot of things with that, but this is one of them. My vision is not that long-term the FCC is continuing to do connected care type of things. It strikes me that, the payors in the healthcare system, are the ones that are realizing the benefits from expanded telehealth. And we got to find a way to, and again, this is sort of outside my expertise, if it's, legislation, if it's, incentives, but long-term, I think the FCC should be stepping back. Again, we're talking a period of years from now, so don't panic. And the payers that are realizing the financial benefits should be picking up, the payments that the FCC is making. And it's not a very well, it's not a specific idea that I have, but just sort of that my general arc is, FCC stepping down as we prove up the value of this, and others sort of stepping in. And is that sort of consistent with your all sort of long-term vision? Or what are your thoughts?
Commissioner Carr, when we did the Senate hearing, that was one of my comments. Who really financially benefits from this is the third-party payers. because telehealth avoids costs. And those are always hard numbers for finance people to gather and put in front of people and have them believe. Our finance individuals in healthcare call those soft costs and soft savings, and it's really hard to get a number on that. But I agree with you that the who's rewarded, if you will, financially are the third party payers, whoever that could be. Medicaid, could be Medicare. It's anybody who is that third party payer. So shifting and having their understanding of the impacts and the outcomes and the reimbursement from the third party payer, DRGs and APCs, all those things are so outdated, as was earlier stated. That fee for service structure, it feels like a redo of that over your long horizon, Commissioner Carr. But that third party payer would, it really needs to take place because we aren't, telehealth is part of the delivery system the same way. We used to have flat plate x-rays. You've heard me say that. Now we have all kinds of imaging, and that's all part of healthcare and part of the scope of care. Just like telemedicine now needs to have its own kind of place in the reimbursement perspective and how we get reimbursed as well.
Dr. True, be able to see sustainable benefits out of the use of telehealth in the healthcare department. And that should support the idea of this is a transition that needs to take place and stay in place, as telehealth is an option that is actually demonstrated the benefits of health response by some of the patients, or most of the patients that are receiving those services through technology advanced approaches. Now, sustainable, it is the same thing as lowering the A1C, lowering your blood pressure, and having those patients avoid a heart attack, stroke, long-term disease, end organ disease, blindness, and need for a dialysis on the diabetic patients with an hemoglobin A1C of 13 and 15 that it's uncontrolled. So the benefits are sustainable through the care and intervention through telehealth, which is a way to reach the clients and the patients at any given point in time without giving them an appointment, making them drive up, find a parking spot, come in late to an appointment, and actually be frustrated. And then when you see them, not only do we have to treat them for their psychiatric conditions and medical conditions, by that time they are out of control many times.
That's right. Yeah. Well, Dr. Trujillo, first of all, if I ever run short of Lysol, I'm coming to your office in Miami. I'm getting stocking myself up. Second of all, I mean, have you seen that the sort of the substitutability during COVID? In other words, the expansion into telehealth, has reduced the traditional in-person services. That's sort of been the trend line that you all have seen.
Yes, I have. Yes, I have. There's only one concern that I'd like to share with this team, and it has to do with the waivers for the provision of telehealth have been great. There's been a waiver for the provision of telephonic health for some of the patients that I provide services for, which I think need to be extended as an option for when there is no other option to contact these patients. And I'm going to refer to you patients who actually are elderly, who have a touch-tone telephone and do not know how to use technology because of cognitive impairment, but still will require services and follow-up for their medical medications and their psychiatric treatment. Many of my patients are living out of disability income and they can pay the bill for electricity. So they do not have a computer. They cannot spend money on computers. They don't have the money to pay the light bill. But when I talk to them on the phone, I can actually get some involvement from my care coordinators to try to get their lights reinstated. So I think I'm making a move to make sure that there is, when there is no other option, this be allowed to be telephone calls. I think it's better than not giving any services at all. Sorry, interrupt.
Sorry, Commissioner Carr, I think you're spot on with your assessment in terms of the long-term vision for the program. I think that, we've done this in other areas in public policy. We have a program that created pots of money for hospitals and physicians to adopt electronic health records, and that support scaled down over time. So I think if you think about the Connected Care pilot program, doing a cost sharing requirement or some kind of phase down of the support and a phase up of the private investment over time seems to make sense to me. And I think the other thing is, I would focus on the smaller providers in areas with the greatest need. I'm not sure, I know you're constrained by law, but, focusing on tax status doesn't make a heck of a lot of sense. to us, because if you're a provider in an underserved area treating very low income patients, that person is going to need a tablet or a remote monitoring program just the same way as if I'm a not-for-profit. So making that distinction, I think, doesn't make a lot of sense in a world where we have, we can identify need much more easily.
Yeah. Well, thank you, everyone. This has been really fabulous to hear from you all. I'll do another quick around the horn, maybe 30 seconds. I think we have a noon East Coast stop, and we may just do that Zoom thing where it just disappears if we go over our allotted time. But I want to express my thanks and appreciation to you all and give each of you a chance, maybe just a quick 15, 30 second sum up of some last words. Dr. Davis, maybe start with you.
Yes. First of all, again, I want to thank you, Commissioner, for the support of our work all of this time. I mean, I'm sure that there are patients, as Dr. Trujillo mentioned, that would thank you personally if they had the opportunity. And also thank you for hearing us today, and learning what else can be done and how you can support us. So thank you.
Thanks. David, you want to go?
Sure. I echo Dr. Davis in thanking you, Commissioner Carr, and the FCC for the generosity and the new opportunities that our health system and many others across the country, hundreds of others at this point, have been able to appreciate. Folks on this call and who are listening in have heard me use words like hybrid and ecosystem and figuring out ways that I think we can just utilize the various and sundry connected health devices, workflows, and opportunities within our communities to really drive health and wellness is the key. And so if we can remove the barriers, decrease the silos and prevent fragmentation from a payer perspective, from a reimbursement perspective on a federal note, and from a licensing and expansion perspective, that's what makes all of this stuff work easier.
Whoops, Deanne?
Yeah. Hey, I echo all the thanks to you, and congratulations, actually, Commissioner Carr, for all that you've really forged out here. The one thing that I want to mention hasn't come up is licensing. And I would say that cross-state licensing is still a conundrum. We're in 34 states. But just underneath that is credentialing. And someday we'll talk more about that. That means the bylaws within each hospital, if you're in an acute care setting, have to approve each one of these physicians. I have hundreds of physicians who are credentialed in 200 sites. It's a conundrum. It's difficult, but not doing that means we don't give care in those rural locations. So we'll talk more, and there's some more ideas around that one.
Absolutely. Dr. Trujillo.
I'd like to thank you again on behalf of my patients, and I'm impressed with the determination with which you've taken this job. For those of us in the trenches, sometimes we feel that we're healthcare providers, nobody up there is listening to anything that we're actually doing that, and we're sitting with the patient dealing with the problem. And I really like to make sure that technology and payers' coverage of technology is advanced to a level where it's compatible with healthcare today. Thank you.
Thanks. Thank you. Joel?
Yeah, I would just echo Dr. Larson's comments. I think that one thing that we didn't talk about was the licensure issues. There's 180 million or so people in employer coverage. That's not a government program, but addressing the licensure issue will help them, and it will help. If we address it in the other government programs, that will dramatically create the case, a business case for expanded telehealth, and we'll do a lot to encourage its use. But I guess what I would say is that everyone says we can't go back, but we will go back unless Congress acts. And so, Commissioner, you've been an evangelist, an advocate. I encourage you to continue to use your seat to tell Congress to pass a law to let us keep the flexibilities that are in place so that we can capitalize on the advances of telehealth.
Well, thanks again to all of you and to America's Healthcare Heroes. Tremendous work. We've got a lot of progress we can continue to make. We can go back, but we shouldn't, and hopefully we won't. And so thank you all very much. Let's stay in touch. I appreciate the chance to learn from your experiences and help build the record here at the FCC and in Washington more generally in favor of expanded telehealth. So thanks, everybody. Really appreciate it. Thanks.
Thank you.
Thank you.